Hey there, Sono Peeps. How's it going? Henry here. So let's go over some hernia cases. This is a great diagram showing indirect and direct inguinal hernias. Now the direct inguinal hernia is going to pouch out here, this area known as Hasselbalch's triangle. Here you can see the inferior epigastric vessels. Here's the deep inguinal ring, superficial inguinal ring, and this is where the spermatic cord goes down into the scrotum. So the bulge is going to be around here. And then with the indirect inguinal hernia, the hernia is going to protrude from the deep inguinal ring, past the superficial inguinal ring, and then into the inguinal canal and scrotum. Now, when doing these scans, I usually begin here in the pelvis, take some sagittal and transverse images, include the bladder. Then I begin my inguinal images, make sure I get the inferior epigastric vessels, make sure I try to get the peritoneal lining, and then follow that down the inguinal canal, showing the spermatic cord. Do that on both sides. I include the scrotal pictures, so transverse and sagittal images of the scrotum, make sure there's no scrotal hernia. And now if the patient says that the mass is not always present, you have them do Valsalva. You could also have them stand upright and scan them upright if the bulge comes out while they stand, using gravity as the force to create the hernia. Now the hernia may contain bowel or it may contain just mesenteric fat, so keep that in mind. Now here's what the direct inguinal hernia looks like. So it's right here in the inguinal canal. It's not protruding all the way down into the scrotum. And here's the hernia defect in a laparoscopic view. This is from the Hernia Center of Southern California. Now they can be unilateral or bilateral. Now it's also important to make sure that if you do see these with ultrasound that they are reducible. You can put transducer pressure here and kind of guide the hernia back in. Now, if it's very tight and with, medium pressure, it doesn't move at all, it can be stuck or incarcerated. And that's important because a incarcerated inguinal hernia is a surgical emergency. So we'll go over this case here, pretty much the protocol I do. So we'll begin in the right inguinal sag. Here's your iliopsoas muscle. And here you can see bowel. You can see subcutaneous fat and a piece of the rectus abdominis muscle. And maybe right here, a little bit of the inferior epigastric vessels. Valsalva images showing no changes. Here you can see the spermatic cord going down into the scrotum. Here's epididymis. Here's right testicle. You see there's no mass here. There's no bulging. There's no intestines. There's no mesenteric fat. And then you can do a panoramic view. So here's your peritoneal lining here. This is the bladder. And the panoramic view all the way down from the inguinal canal down into the scrotum. All right, so this side is normal. And we do the left inguinal canal. So I'm kind of angling from lateral to medial. And here again, this is the penis. So this is the base of the penis. Corpus cavernosum, corpus cavernosum, corpus spongiosum. Now, this is sometimes mistaken for a lesion or a mass, but be aware of the anatomy of the penis. All right, so here you can start seeing something pouching out over here. Not very obvious. Usually in real time, that's why you take clips. All right, so go down all the way from the inguinal into the scrotum. Little epididymal, not little, medium to large epididymal head cyst, spermatic cord. And then here you have your panoramic view going down from the inguinal canal down into the scrotum. So now here's with Valsalva, you can, in real time, you see some outpouching right here. So this would be like the neck right here. And I sometimes like to trace it, especially in this case, there's no bowel. There's only fat, mesenteric fat protruding into the canal. Take images of the scrotum, show that there's no scrotal hernia. There's no bowel or hydrocele or anything like that into the scrotum. Again, you can see it's protruding out into the inguinal region. Very subtle, much more obvious with clips, which I'll show you now. Here's with Valsalva. Again, fat, a little bit of fluid. Here's another image standing up, and you can see the protruding of the fat into this area here. Inferior epigastric vessels here. I also like to take pictures of the bladder, usually just a couple sag and trans. Now let's look at the clips. So here's the left inguinal. Upright, here you can see the hernia right here. This is your inferior epigastric vessels. And like I said, it's also important to make sure that these hernias are reducible. So with slight transducer pressure, you see it going whoop right back in. So that's just slight transducer pressure. If you have to press a lot, and you know when it's incarcerated, it's very tense and usually they usually have a lot of pain. Again, you can see the inferior epigastric vessels right there. And here's another clip, still patients upright. You can see the hernia going in right here and also a little bit of bowel. And then with pressure going back in. So this is a reducible direct inguinal hernia. On to the next one. Here we have another. Here's your right testicle and sagittal and transverse dual screen. Right, here's your inguinal canal. A little bit of fluid there. Tiny hydrocele. No big deal. But then here, you're going to see some stuff protruding into the inguinal canal and is going down into the scrotum. So that's bowel. Now, so here you got your left inguinal canal into scrotum with valsalva. You can see a lot of stuff going into the inguinal scrotal region. So a pretty large hernia with bowel. The right inguinal canal also had a hernia. And actually this here is the appendix. So the appendix is going over here into the inguinal scrotal region with some free fluid. So this is bilateral indirect inguinal hernias. Here you got a transverse view of the scrotum. So right testicle, left testicle, a little bit of free fluid here, a little bit of hydrocele. And here you can see the bowel in the scrotum right here, doing a lot of peristalsis. Here's the right side again, and much clearer you can see the appendix right here. So at least they didn't have appendicitis. And here's bowel. Again, showing the appendix and the hernia there. And the much larger left indirect inguinal hernia. Here you can see is the neck right here, and you can see all this is bowel going down into the scrotum. And here's a clip showing the reduction of the hernia with transducer pressure, and then the hernia going back into the canal. On to the next one. Here's another case of an indirect inguinal hernia. This one is unilateral, and on the left, here you see a testicle and sagittal trans with a hydrocele, and then this complex area here. So here's a panoramic view showing a large inguinal scrotal hernia with complex fluid here and hydrocele. This was not reducible. It was very tight. No matter what pressure you put, it was not reducible. So this is one that they usually have to call, the surgical on-call team so they can evaluate the patient. Another panoramic still, so very large inguinal scrotal hernia. Here you see bowel with gas in this complex collection here. So here we have where the defect is, or the neck of the hernia. You can see the inferior epigastric vessels here. And another panoramic showing the neck right here. And then this complex fluid collection. Now when this bowel is incarcerated, they are at risk for ischemia and infarction. So this is a surgical emergency. So here's a clip showing the hernia. You see peristalsis, the complex collection here. And this is with pressure. And the hernia would not reduce at all. Now, they came with the hernia already present, so you didn't have to do Valsalva to induce the hernia because it was already present from the get-go. So again, you can see this bowel is distended, and you can see the contents of the bowel there. And this is why clips are important, because you can show that there's peristalsis, or you can show that it's fat, or fat and bowel, and you can show that it's reducible or not reducible, or that you can create the hernia with Valsalva. And here's a clip from the beginning of the hernia trekking down into the scrotum. So a bowel against that complex fluid around the bowel. Very interesting case. All right, on to the next one. So females don't have scrotums, but they do have tracts of tunica vaginalis similar to the tract you would see going down into the scrotum. And this is called the Canal of Nook. You can have a Canal of Nook hernia, which can be just fluid, so like a hydrocele, bowel, or can include the ovaries or the ovaries and uterus. So here I begin in the suprapubic region. I spelled pubic wrong, so LOL. And here you can see the symphysis pubis right here. You see the cartilaginous portion of the symphysis pubis. At least I fixed the text. All right, so here in the inguinal canal, you can see there's a lymph node. No big deal. Iliopsoas muscle. And then in the left inguinal canal, you can see a hernia. So you can see a channel right here opening up, inferior epigastric vessels. And you see this going into the vulva region, and then track it down just like you would in the scrotum. This is in transverse right here. And this is the left ovary. So this was a Canal of Nook hernia with a left ovary in it. Once you see that, you want to Doppler the ovary too. Make sure it's got good blood flow. You see the follicles there. So Doppler it, color Doppler, spectrodoppler. Make sure it's got good blood flow, that there's no torsion, because that would be a complication of this. Now let's look, and with pressure, it was reducible. So you see this is that area with slight pressure. The ovary was able to go back into the peritoneum. Let's look at some clips. So here you can see this clip tracking down. You can see adnexa here, adnexal tissue, could be fallopian tube, could be a broad ligament, and then the ovary over here. And then the same area with a little bit of pressure. They're slippery, so sometimes you could fall off of it, but with a little bit of pressure, it was able to go right back there into the peritoneum. So these can also be incarcerated, so that's also good to note. So here's adding pressure, watching it go in, and then with Valsalva. And you can see there's also some bowel into this hernia. And here we have another case with vulvar swelling. So transverse vulva, you can see there's two cystic structures here. These are hydroceles. So similar to like you would see in a scrotum with Canal of Nook hernias, you can see Canal of Nook hydroceles. And here you can see with Valsalva, the structures protruding into this hydrocele. That's an ovary on the left inguinal. And with slight pressure, the ovary was able to go back into the peritoneum, although the fluid stayed within the sac. As you can see here on this still with transducer pressure. And here is another case of Canal of Nook hernia. In this case, the uterus and right ovary are protruding into the canal, and you can see the left ovary is still within the peritoneum. All right, well, hope you found this useful. Take care. Bye.